based approach. Um, can we have the slides, please? So I thank all my co-instructors for consenting to be part of this course, and I thank Dr. Ranjana, our keynote speaker, for consenting to be a part of this as well. So just to give an overview of the course, we'll start with the introduction, and then we'll go into the basics of each of the tests. We'll start with ERG, EOG, yes. And so we'll start with ERG, EOG, go on to pattern ERG, multifocal, and then we'll have some clinical cases from Dr. Ranjana as the keynote address, and then finally we have Dr. Rohit with VEP. So coming to the introduction. Now first let me start by saying what is special about electrophysiology. Of course, like other tests, it's important for diagnosis and monitoring of eye diseases, but it's a functional test which is of which has a valued role in this age of advanced ocular imaging. It also allows us a dissection of the visual system where we can ascribe function to the various layers right up to the visual cortex. And importantly, this information is objective. It requires minimal cooperation. Like any other tests, all these tests need to be placed in the clinical context, so a thorough clinical evaluation is mandatory. Let me say right here that ERG, EOG, in fact, all of electrophysiology is not like our other tests where we can, just give an OCT scan or a field and ask quiz about the diagnosis, that what do you think this is. So we can have very similar ERGs or VEPs in absolutely varied conditions, so please don't use it as a test, use it in your clinical context. So these are the tests we'll be talking about, and these are the 5 ICEF standard clinical tests. Basically what they do is the light causes graded ionic changes in the retina. This stimulates the bipolar and finally the retinal ganglion cells to signal along the optic nerve to the cortex. And this is the information which is utilized in our test. There's a primarily vertical pathway of information flow, and that is bisected by each of these tests. There are varied diseases which affect this, which we hope to learn through this course. Now, the origin of these test signals is basically determined by 1, the visual stimulation characteristics, 2, the electrode placement, and 3, the state of light or dark adaptation. And this is a summary also of the time that each of these tests takes. Of course, full field ERG takes the longest. Now, a minimum of 3 electrodes is needed to detect difference in potential between 2 sites over time. You have an active electrode, an inactive electrode, and a ground electrode. So for EOG, that is the one which gives us the value in millivolts. You have electrodes at the canthi which are sensitive to eye movement. After this, you have ERG, which gives the values in somewhere hundreds of microvolts, where you have corneal, we prefer corneal electrodes at the outer canthus. And then finally for the VEP, which has the lowest of these, around tens of microns, you have electrodes placed over the occiput referred to the forehead. Now, these are the various electrodes which are available. They can be corneal or non-corneal. Now, the closer the electrode to the cornea, the better amplitude you get, though the latency will not change. And DTL and gold foil are the only 2 which allow clear pattern stimulation. Cost-wise, DTL is more cost-effective. Now, this is a typical picture of DTL electrodes in place. For VEP, and of course these are disposable, so you have to use a new one for each patient. For VEP, you have standard silver chloride or gold disc EEG, the cup electrodes which are used, and these can be reused for patients. You have an active electrode at the occiput, a reference at the forehead, and the ground at the earlobe. Now from these electrodes, the signal goes into the preamplifier, and finally an amplifier which is needed to make these microvolt signals readable and analyzable. We use various filters to window the response of interest and averaging to improve the SNR or the signal to noise ratio. Now, what are the stimuli that we use? First, as you can see above, this is a typical Gans field stimulation, which stimulates the entire retina uniformly, mostly in the full field ERG. To note, the pupils are dilated in this test so that you can standardize the amount of illumination reaching the retina. The second stimulus that we have are these patterns. Now these are employed in pattern ERG and pattern VEP. There are equal number of black and white elements. The patient has to focus, so you use natural pupils. Again, easy to remember. And then finally, we have these multifocal ERG and less commonly available multifocal VEP tests, where you have equal number of black and white hexagons which are generated in a pseudo-random sequence. Now, a word about ICEV, the International Society for Clinical Electrophysiology of Vision. They have a website, and all these tests, the way they should be done ideally, is given free at this website. So I would recommend that everybody please go through it. So the purpose is so that there is of standardization, so that there is uniformity across labs. And ICEV also encourages that every lab should have its own normative data, which is age and sex match, which you should do if you have just bought a machine. So just to revise, the EOG looks at the RP, the ERG, which can be flash, multifocal or pattern, looks at the retina right from the photoreceptors till the ganglion cells, and the VEP from the ganglion cells up to the visual cortex. Now, what about the area of retina that is stimulated? For ERG and EOG, remember that these are mass responses. So the macular contribution is negligible, and it's a global response of the entire retina. If you want to specifically see the central retina, then you have to use a pattern, which can be a pattern ERG or the multifocal ERG. And about pattern VEP, please remember that it is, yes, a function of the optic nerve, but it is also highly contributed by the macular pathway. So the results are displayed as graphs. What we look at is the size or the amplitude and the time to peak, which is the latency. This is what a typical normal full field ERG looks like. Though we'll be looking at it in detail, you should be able to look at it and recognize the waveforms. I've noted where each of these waveforms are hypothesized to originate from, and of course with time you'll get familiar with that. Please also remember there are some non-standard ERGs. For example, we can test the long and medium wavelength cone systems with the red and blue ERG. Then we can check the short wave again with the blue ERG, and the photopic negative response again using a red flash of 650 nanometer, useful in glaucoma. But these are mainly for research purposes, or if you have a unique case like ESCS Goldman-Favre, that is to consider. Now PERG, this is what a PERG looks like. We look at the P50 and the N95 waves. A multifocal ERG, again we'll be looking at this in detail. A pattern VEP, the parafoveal and foveal response. A flash VEP, the P2, and then finally a EOG. So again, to just get familiar, on ERG the waves are named ABCD. On PERG and pattern VEP, it's positive or negative followed by the time. And in multifocal ERG and flash VEP, it's in the order of appearance. How to analyze? If the amplitude is decreased, it means there is cell death or lesser number of functioning cells. And if the latency or implicit time is increased, it means there are more number of sick or dysfunctional cells. And you must always compare with the normative database. So the aim of this IC is to simplify visual electrophysiology for all of us so that we feel more comfortable using it in our clinical practice. And now